Pancreatectomy for localized pancreatic ductal adenocarcinoma. Oncological resection of the primary tumor is necessary, but in most patients with localized pancreatic ductal adenocarcinoma, insufficient for long-term survival. So, evidence for the benefit of resection over the best non-operative management, that is chemoradiation, has been tested and established a single randomized control trial. Total of 42 patients in Japan, they were randomized to standard pancreatectomy without adjuvant treatment or chemoradiation alone. Radiation was 50.4 gray with continuous 5U at 200 mg per meter square per day without surgery, and randomization occurred at laparotomy. The only multivariate predictor of survival in the study was treatment group, with the resection cohort having the superior survival of 13 months versus 9 months. And long-term results of this trial demonstrated that the 5-year survival rate of patients, 10% of the patients who underwent resection compared to 0% who did not. So technical details and nuances of the pancreatectomy, they are beyond the scope of this, but we provide a brief review about at the most basic level. The choice of operation is pancreatic or duodenectomy. Distal pancreatectomy is splenectomy. Total pancreatectomy is based on the anatomical relationship between the primary tumor and the gastroduodenal artery. As this blood vessel is the general landmark for the location of the intrapancreatic portion of the distal common bile duct. Tumors to the right of the GDA require pancreatic or duodenectomy, and the surgical specimen includes duodenum, proximal jejunum, pancreatic head, neck, uncinate process, common bile duct, and gallbladder. The most proximal retained jejunum is mobilized to the right quadrant, and gastrointestinal continuity is restored with anastomosis of the pancreatic remnant, pancreaticojejunostomy or gastrostomy, common bile duct hepaticojejunostomy, proximal duodenum duodenojejunostomy or pylorus preserving, stomach gastrojejunostomy, and classical PD or pylorus ring resecting pancreatic or duodenectomy. And the value of pylorus preservation compared to resection has been widely studied, with heterogeneous results that do not seem to be favor one technique over other. Meta-analysis of Hutter et al. 8 randomized RCT of 512 patients, no difference in post-operative morbidity, OS mortality, and there was reduced delayed gastric emptying favoring pylorus resection, and the operative factors such as time estimation, blood loss, transfusion favored pylorus preservation. And multiple RCTs have been examined for the location of the gastro or duodenojejunostomy. No significant difference were observed in a recent meta-analysis of Vanges and colleague reported pylorus resection with anticolic gastrojejunostomy, and modification had the lowest association risk of DGE, and the extent of lymphadenectomy standard versus extended of pancreatectomy has been analyzed, and none shows improved oncological outcome in patients who underwent extended node dissection, but patients undergoing extended lymphadenectomy experience higher morbidity. Tumor to the left of the GDA approach distal pancreatic or splenectomy, and this involves resection of the pancreatic body, tail, and block with the spleen, and the pancreatic stump is typically transected with a staple or overseen with the sutures, and post-operative pancreatic fistula remains the principal morbidity. Clinically significant leaks occur in approximately 15% of the patient based on the recent analysis over 2,000 cases, and there have been numerous randomized control trials testing the efficacy of the transection technique, staple line reinforcement, sealants, suturing of the pancreatic stump, somatostatin analog. No intervention have demonstrated consistent reproducible mitigation of this post-pancreatic fistula, and in above cited by Vollmer and colleague, none of these methods were associated with the reduced rate of post-pancreatic fistula. And asplenic patients require vaccination against streptococcus pneumonia, Nigeria meningitis, and Haemophilus influenza type B. Tumors that extend from the left of the GDA into the pancreatic head may require extended pancreatic duodenectomy or total pancreatectomy, and for total pancreatectomy, duodenum, proximal jejunum, common bile duct, gallbladder, pancreas and blocked with the spleen removed, and the proximal retained jejunum is brought to the right upper quadrant, and hepaticojejunostomy, duodeноjejunostomy or gastrojejunostomy, they are performed in a similar fashion to pancreatic or duodenectomy. Patient who underwent total pancreatectomy will require pancreatic enzyme replacement, lifelong insulin therapy, and close glycemic control. Hypoglycemic episode from lack of glucose production can be life-threatening. As with distal pancreatic splenectomy, patients with asplenic after total pancreatectomy require triple vaccination administration, and a high-volume pancreatic surgeon is an essential component of multidisciplinary management. Minimally invasive pancreatectomy, like robotic or laparoscopic approach in pancreatic surgery, has been utilized in the increasing frequency for the post-decade for both benign and malignant indications. Leopard study. There was randomized RCT performed for Dutch pancreatic cancer group compared open to minimally invasive distal pancreatectomy in 107 patient who underwent minimally invasive distal pancreatectomy has less blood loss, like 150 ml versus 400 ml, longer operative time, and similar post-op morbidity, including post-op pancreatic fistula. Functional recovery was achieved in 2 days sooner in patients minimally invasive group. And diploma study, that is a non-inferior trial designed to test oncological outcome between the open and minimally invasive distal pancreatectomy in patients with the left-sided pancreatic adenocarcinoma actively accruing. And based on this published data, minimally invasive distal pancreatectomy appears to be safe and feasible approach to patients with left-sided cancers when performed with experienced pancreatic surgeon. Minimally invasive pancreatic duodenectomy remains area of controversy, and the first laparoscopic pancreatic duodenectomy was performed by Gagner and Form